this pandemic, people struggling with depression and anxiety themselves and unsure where to go for help, communities fighting a rise in substance abuse, as well as a surge in overdose deaths fueled by a deadly increase in fentanyl use, and mental health and substance use disorder professionals who are feeling overworked, overwhelmed, and just burned out. We all want to address these challenges, which is why Senator Burr and I are working in a bipartisan way on legislation to support our communities and help people get the services for mental health and substance use disorders that they need. We continue to make progress on that effort, and our hearing today represents another important step forward. I spoke last time about the work that Lifeline Connections and Neighborhood House and the Confederated Tribes and Bands of Yakima Nation and other local organizations are doing to address the mental health needs of families in Washington State. And I'm glad to have this opportunity to discuss how the federal government can better support frontline efforts to screen and provide services for mental health challenges, support people who are struggling with substance use disorder, increase access to addiction treatment, prevent drug overdoses and suicide, and more. Because COVID-19 has made it clearer than ever that while our communities are doing valuable life-saving work, we need to do much more to help them. Youth health emergencies have skyrocketed during this pandemic, with sharp increases in kids' visits to the emergency room for mental health crises, thoughts of suicide, suicide attempts, especially among girls. And as of February, over 200,000 children have had their world shattered after losing a parent or caregiver to COVID-19. This pandemic has also set us back catastrophically when it comes to substance use disorders. We saw an estimated 106,000 drug overdose deaths in a single year. That is a record high. And fentanyl has been especially devastating for families in my state. Fentanyl deaths in our largest county doubled last year. But nationally, we're also seeing a concerning rise in methamphetamine and cocaine use. Meanwhile, our mental health and substance use disorder workforce, which was already stretched thin, is nearly threadbare. I said this before, but it really stands out to me that almost 130 million Americans live in areas with less than one mental health provider per 1,000 people. And in my home state of Washington, our mental health care workforce is only able to meet 17% of our state's needs. Meanwhile, nationwide, not even a tenth of people who need treatment for substance use disorder actually get it. And these problems are especially pronounced for rural areas, communities of color, and people with disabilities. And it's important to remember that the many people who are personally facing mental health and substance use disorders or struggling to get the support they need aren't the only ones feeling this. We all have friends and family who are, whether we realize it or not. We all rely on first responders, healthcare providers, and other frontline workers who are experiencing burnout and trauma. We all have a stake in making sure people can get the help they need. So let's make sure we act accordingly. Now, we aren't starting here on square one. We have a long bipartisan track record of addressing mental health and substance use disorders in this committee. But we're also not close to where we need to be, especially considering the ways this pandemic has worsened pre-existing challenges. We need to rise to this moment by strengthening the tools that communities are already using effectively to help people get care and providing new ones to address the gaps and emerging issues this pandemic has made so much worse. That means putting together a bipartisan package that supports suicide screening and prevention, helps schools and communities meet kids' mental health needs, reduces drug overdose deaths and gives patients more options to get substance use disorder treatment, addresses the mental health needs of new mothers, tackles barriers that make it hard for people to get the care they need, like stigma, health inequity, and a strained workforce, and more. I know members on both sides of the aisle share these goals and have ideas about how to make them a reality, and I look forward to continuing to work with all of you on this. As Ranking Member Burr and I have announced, it is our goal to pull the committee's mental health package together in early summer so we can move legislation to the floor. We both hope to have more to say on that in the days ahead and appreciate the many ideas that members on and off this committee have for the package as we work together to address this crisis. This pandemic has done so much to damage our nation's mental well-being. There are so many people who are stressed and anxious and traumatized, struggling with addiction, or who are grieving over the loss of a loved one and don't know where to turn. But there are also people in our communities who care about them and who are working right now to get them help. So as this committee works on bipartisan legislation to reauthorize and improve federal programs on mental health and substance use disorder, I look forward to hearing from all of our witnesses today about the steps that we can take to help bolster the efforts of those on the front lines of our mental health and substance use disorder crisis and make sure that every person who is struggling can get the care they need without worrying about stigma or cost, without having to travel for hours or wait for weeks, and without feeling like they're all on their own. With that, I will turn it over to Senator Burr for his remarks.
Thank you, Madam Chairman. Thank you for holding this hearing. Even before the pandemic, we knew the need to address mental health and substance use disorders were dire. Opioids took hold, and the results were a crisis with families and communities who had not dealt with that for some time. As we look to reauthorize a number of these programs, we face problems that have been compounded by the pandemic, but can be informed by our COVID response. We learned that research, innovation, partnerships, and real-time data are the key to our success in overcoming an unprecedented public health challenge. Today's hearing will help us determine how to apply these lessons and those actions to mental health and substance use challenges that continue to devastate our communities. The last time the committee examined our mental health and substance use programs, we heard from Sam Quinones, on opioids, who shared his belief that isolation and lack of community was a driving factor in the substance use disorder crisis facing America. Isolation only worsens when the pandemic struck. Months on end of remote learning, time separated from aunts, uncles, grandparents, friends, teachers, families, with critically ill and dying loved ones who could not say goodbye, has taken a tremendous toll on America, especially on children. We're seeing the results of the past 2 years in an alarming rate of people, particularly young children, arriving in the emergency room in a state of mental health crisis. In 2020 alone, the number of young people seeking care for their mental health in the emergency room increased by 31%. Between 2016 and 20, the number of children experiencing depression increased by 27%. Number of children experiencing anxiety rose by 29%. Last year, more than 100,000 people lost their lives to drug overdose, a nearly 30% increase from the year before. 2/3 of these adults were linked to synthetic opioids such as fentanyl. But in the face of these tragedies, we see strength and resilience. Families turning tragedy into action to bring awareness and understanding to help others. In hearings over the past year, we've heard examples of leaders in local communities ready to meet these challenges, partnering to bring local solutions to address local challenges. As we consider reauthorizing these programs, it would serve us well to remember this too. Since 2016, we've authorized or reauthorized more than 40 different federal programs to address mental health and substance use disorder. In addition, the fiscal year 2022 Omnibus Appropriations Bill provided nearly $5 billion for mental health and substance use disorder-related programs. But at least 9 of these authorized programs did not receive funding. We've seen time and time again that creating a new program that does not get funded is a false promise. That creating new programs for the press release at a markup isn't actually a solution. So we need to figure out what we can do with the tools that we have and improve the current programs and fund the programs that we do create. We should be honest with ourselves and the country and terminate the programs that haven't received funding in the last 5 years. If a program hasn't received funding, it shouldn't stay on the books. We'll have to prioritize and answer key questions like how to better target our programs to make sure that they're both meeting the needs of today, but also have the flexibility to address the needs of tomorrow. To our witnesses, welcome. We need your expertise to ensure we have the right performance measures in place to track progress in the programs you oversee. GAO recently found that many of our mental health and substance abuse programs lack the measures we need to know whether the programs work. You only know what you can measure. If we cannot track programs in a meaningful way, we'll not know how to improve the programs to better meet the needs of the people that are intended to be served and reprioritize those that are underperforming. Additionally, we need to make sure that we are using up-to-date data to inform our response and addressing emerging issues. States and local communities must be empowered to address these issues, and they need accurate information to identify the problems that they're facing, like emergence or reemergence of a new drug in an area or identifying increased rates of suicide in certain populations. Sometimes this requires thinking outside the box. We saw communities pull together during the pandemic to come up with solutions that worked, and we need the same spirit and ingenuity with this challenge. One of the trends in that success was partnerships with the private sector. Local public-private partnerships are the foundation of many of our successful federal mental health and substance disorder programs. I look forward to hearing more about how Samsa is encouraging partnerships and facilitating local engagements through these programs and how this can be improved going forward. Leveraging innovation to help address our mental health and substance use disorder crisis is another area I look forward to focusing on and hearing more about. Critical to all of this strong workforce, this committee reauthorized a number of health workforce programs in 2020, in addition to those included in the pandemic package. The health workforce, particularly our doctors, nurses, counselors, and therapists, have been through a lot. They rose to the challenge during this pandemic, and it's taken its toll. Earlier this Congress, the committee passed the Dr. Lorna Breen Healthcare Provider Protection Act, which was just signed into law, to make sure that these providers get the support and care they need for their own mental health and substance use concerns, especially as they continue to care for all of us. Madam Chairman, I look forward to hearing more about how HRSA is leveraging and prioritizing existing federal health workforce programs to fill gaps in mental health and substance use disorder workplace. I yield the floor.
Thank you very much. With that, I will introduce today's witnesses. Our first witness is Dr. Miriam E. Delphin-Rittman. She's the Assistant Secretary for Mental Health and Substance Use at the Department of Health and Human Services, who leads the Substance Abuse and Mental Health Services Administration. Welcome. Good to see you here today. Our next witness is Ms. Carol Johnson. She's the Administrator of the Health Resources and Services Administration. Welcome to you. We're also joined today by Dr. Joshua Gordon, the Director of the National Institute of Mental Health. We appreciate you being here today. And our final witness is Dr. Nora Volkov, Director of the National Institute on Drug Abuse. Thank you for being with us as well. With that, we will start with you, Assistant Secretary Delphin-Rittman.
Thank you, and good morning, Chair Murray, Ranking Member Burr, and members of the committee for inviting me here to testify today. I'm the Assistant Secretary for Mental Health and Substance Use at Samsa, the agency that leads the public health efforts to advance the behavioral health of the nation and improve the lives of individuals living with mental health and substance use disorders, as well as their families. It is an honor to lead this agency, and I am a proud product of one of its programs, the Minority Fellowship Program. I am pleased to be here with my colleagues from HHS, from HRSA, and NIH to discuss the growing mental health and substance use challenges that we're facing as a country. As President Biden noted, our country faces an unprecedented mental health crisis among people of all ages and backgrounds. Even before the pandemic, rates of depression and anxiety were inching higher. but grief, trauma, physical isolation of the last 2 years have driven Americans to a breaking point. In addition, drug overdose deaths have reached a historic high, devastating families and communities. More than 104,000 Americans died due to drug overdose in the 12-month period ending in September 2021. For these reasons, the Biden-Harris administration has included addressing mental health and addiction as 2 of the 4 pillars of the Unity Agenda that was outlined in the President's State of the Union address. Samsa is actively working to advance the Unity Agenda, including helping to implement the National Mental Health Strategy. This strategy includes strengthening capacity, connecting more Americans to care, creating a continuum of support that aims to transform our health infrastructure to address mental health holistically and equitably. To help SAMHSA advance this mission, I've identified 5 core near-term priorities for the agency. The first is preventing overdose. Given the escalating overdose crisis and the negative impact of COVID-19 pandemic, the HHS has created a new comprehensive overdose prevention strategy meant to strengthen our primary prevention efforts and increase access to a full continuum of care and services for individuals with substance use disorder and their families. The second is enhancing access to suicide prevention and crisis care. Preparing the National Suicide Lifeline for full 988 operational readiness requires a bold vision for a system that provides direct, life-saving services to all in need and links them to community-based providers uniquely positioned to deliver a full range of crisis care services. SAMHSA sees 988 as a linchpin and a critical catalyst to transform the behavioral health system of care. The third is promoting children and youth behavioral health. To focus our efforts on improving behavioral health wellness for our nation's youth, SAMHSA has developed the HOPE framework, health, opportunity, potential, and equity for children, youth, and families across the country. The fourth is integrating primary care and behavioral health. We know that individuals' first interactions with the health system is typically through a primary care provider or an emergency room. During the COVID-19 pandemic, while providers were initially focused on acute medical concerns, we heard that many were not adequately resourced to consider the behavioral health effects of the pandemic. The fifth is using performance measures, data, and evaluation. For example, SAMHSA recently released the Behavioral Health Equity Report 2021, drawing on data from our National Survey on Drug Use and Health. My written testimony also outlines 4 additional cross-cutting principles, several SAMHSA programs that bolster our work to support these priorities. These principles are greater equity within the behavioral health system, enhancing the behavioral health workforce, promoting and supporting recovery practices, and working to ensure financing of a robust behavioral health system of care. I will close by echoing President Biden's call in his State of the Union to support the millions of Americans who are in recovery. Early on and throughout my career, I've been inspired both personally and professionally by family members, friends, colleagues, and acquaintances who with courage and resilience have striven for wellness and recovery. On behalf of my colleagues at SAMHSA, I want to thank you for your interest and support for our programs and for supporting the nation's behavioral health. I look forward to answering any questions that you have. Thank you.
Thank you. Administrator Johnson.
Good morning, Chair Murray, Ranking Member Burr, and members of the committee. I'm Carol Johnson, Administrator of the Health Resources and Services Administration. I appreciate the opportunity to speak with you today about HRSA's programs that support the mental health and well-being of our nation. As you know, HRSA supports healthcare services in communities across the country, including, for example, for the nearly 29 million people who receive care through HRSA-funded community health centers, the more than 500,000 people diagnosed with HIV who receive care through the Ryan White HIV/AIDS program, about 60 million pregnant individuals and children who benefit from HRSA-funded infant screenings, preventive care visits, and other services, and individuals in more than 1,500 rural counties who receive HRSA-supported substance use disorder services. HRSA also plays an important role in supporting the healthcare workforce. We provide scholarship and loan repayment assistance to thousands of clinicians in return for them practicing in underserved communities. This year marks our largest scholarship and loan repayment cohort yet, with more than 22,000 clinicians in these programs. We also invest in recruiting, training, and retaining health professionals, from community health workers to mental health professionals to advanced practice nurses. And like you, we recognize that mental health is essential to overall health for people of all ages, including for parents and children who have been affected by the pandemic. So today I'd like to highlight 2 HRSA maternal and child mental health programs that are currently up for reauthorization: the Screening and Treatment for Maternal Depression Program and the Pediatric Mental Health Care Access Program. The Screening and Treatment for Maternal Depression Program supports states in integrating mental health care into maternal health care. There's tremendous demand for this program, but to date, we've only been able to fund about 1/4 of the applicants. Grantees provide training to help maternal health care providers screen and treat their patients' mental health conditions. And in a critical part of the program design, grantees give maternal health care providers the opportunity to connect with mental health care clinical experts through teleconsults to help them treat their individual patients' mental health conditions. As a result, more pregnant and postpartum women are being screened for depression, and maternal care providers are growing their capacity to support the mental health needs of their patients. Of note, where those needs are more complex, maternal care providers have the benefit of an expert teleconsult to support them. For example, through our program, a midwife in Montana and her pregnant patient with emergent mental health needs got real-time mental health help from a perinatal psychiatrist through teleconsultation. In the normal course of business, the midwife would have had to refer the patient to a provider hours away who likely would have had trouble easily squeezing the patient in. Similarly, the Pediatric Mental Health Care Access Program promotes mental health care integration in pediatric primary care. These grants provide teleconsultation, training, and care coordination to help local pediatric primary care providers diagnose, treat, and refer children for mental health care. Similar to the maternal depression program, our pediatric program both provides training that's building the capacity of pediatric primary care providers to respond to children's immediate mental health care needs, while also giving them the additional support of teleconsultation with a mental health expert to ensure that they have backup and the resources they need to serve their patients. Funding from the American Rescue Plan allowed us to broaden the program's reach from 21 to 45 states, territories, and tribal areas, and we are currently taking additional applications as well. There's considerable interest and demand for these programs, and we look forward to working with the committee on their reauthorization. In addition to our programs that support mental health services, HRSA's workforce programs are training the behavioral health workforce and creating incentives to encourage them to practice in the communities where they're needed most. Our behavioral health workforce education and training program supports the training of psychologists, school and clinical counselors, marriage and family therapists, as well as the critical community connectors to mental health and substance use disorder care, like community health workers and peers and others. And our scholarship and loan repayments are increasingly supporting behavioral health care providers as well. We also recently launched a new program with American Rescue Plan funding to help support healthcare workers' mental health resilience and reduce provider burnout. In closing, I want to thank the committee for your ongoing support for HRSA's programs and your commitment to the mental health and well-being of America's families. Thank you.
Thank you. Dr. Gordon, Director Gordon.
Chairwoman Murray, Ranking Member Burr, members of the committee. The Biden administration is committed to addressing the unprecedented mental health crisis affecting communities across the United States using a strategy built on a foundation of research carried out by the National Institute of Mental Health, the lead federal agency charged with setting and supporting the national agenda for mental health research. It is my privilege to represent NIMH before you today and to discuss our ongoing collaborations with partner agencies to support the President's strategy. The NIMH is one of 27 institutes and centers of the National Institutes of Health. NIMH's mission is to transform the understanding and treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. Guided by our strategic plan, NIMH supports a research pipeline that includes basic efforts to understand the brain and behavior, translational science focused on developing transformative new therapies, and clinical research aimed at maximizing the public health impacts of these therapies. The translational pathway is well illustrated by considering one recent advance in the treatment of postpartum depression, a mental illness that impacts 1 in 9 mothers and can be life-threatening. Working diligently over decades, neuroscientists supported by NIMH discovered that a naturally occurring brain chemical might have a role in postpartum depression. This led to the eventual FDA approval of brexanolone, an analog of that chemical, as the first ever drug specifically for postpartum depression. NIMH's role doesn't stop with the development of transformative therapies like brexanolone. We also collaborate extensively with other federal agencies with the goal of ensuring that effective treatments are accessible to all who need them. One such collaboration has transformed care for psychosis in the United States. An ambitious NIMH-supported research program, the RAISE initiative, proved that coordinated specialty care could cost-effectively improve outcomes for those experiencing their first episode of psychosis. Based on these findings, our colleagues at Samsa used the Mental Health Block Grant Program to fund first episode psychosis clinics across the country. Now, over 350 such clinics are providing this cutting-edge care to thousands of Americans each year. NIMH collaborations are also making progress in preventing suicide. NIMH research forms the backbone of the Zero Suicide approach, a systematic framework for suicide prevention supported by Samsa, the Department of Defense, the Indian Health Service, and numerous others. For example, NIMH research has demonstrated that emergency room screening for suicidal thoughts, combined with brief interventions and follow-up contacts, can reduce suicide attempts by 33%. NIMH continues to work with public and private partners to promote the use of zero suicide and other evidence-based approaches. And while it is too early to declare victory, we were gratified to see rates of death by suicide decline for 2 consecutive years following 2018, after 2 decades of inexorable increases. The COVID-19 pandemic has brought additional challenges to the mental health system. The rates at which individuals note symptoms of depression, anxiety, substance use, and suicidal thoughts have all gone up, as has the demand for mental health services, especially amongst children. These impacts have not been felt equally, with Black, Latinx, and other underserved communities, as well as care practitioners and others on the front lines of the pandemic, bearing the brunt of both the physical and mental health impacts. Yet, even during the pandemic, research has offered hopeful solutions. NIMH research showed that telemental health care can be as effective as in-person mental health care, supporting the rapid switch to remote care in early 2020. NIMH research during the pandemic has also demonstrated that social supports, such as providing meals to families threatened by food insecurity, builds resilience to the mental health impacts of the pandemic. Additional challenges await solutions. The Surgeon General has declared a crisis in youth mental health, noting the impacts of media and technology use and the rise in suicide rates among Black youth and other vulnerable groups. We also face continuing challenges in caring for individuals with serious mental illness and the equitable delivery of mental health services. To address these challenges, NIMH continues to collaborate with our federal partners, including those joining us today, to ensure that evidence-based solutions reach those in need. In short, we stand ready to help. Thank you for your opportunity to provide this testimony, and I'd be pleased to answer any questions you might have.
Thank you, Director Volkov. If you can turn your mic on.
Can you hear me?
Yes.
Yes. Good morning, I was saying, and Chairwoman Murray, Ranking Member Burr, and members of the committee. Thank you for inviting me to speak to you today. The Biden administration is committed to addressing the unprecedented mental health and substance use disorder crisis affecting our country. And I welcome the opportunity to discuss how research supported by the National Institute on Drug Abuse is advancing this goal. We are experiencing the worst drug overdose crisis in the nation's history. Exacerbated by the COVID pandemic, overdose deaths have escalated across states and demographics. Now, for the first time ever, we're seeing fentanyl overdoses in adolescents rising dramatically. Substance use disorders frequently co-occur with other mental illnesses. Half of people with mental illnesses will have a substance use disorder at some point in their lives, and the reverse is also true. These conditions share many common biological and environmental risk factors, such as discrimination, trauma, and economic deprivation. Since 2016, the rise in overdose fatalities has been driven by potent synthetic opioids, primarily fentanyl. In the meantime, social isolation and stress during the pandemic have contributed to a rise in emotional suffering and an increase in substance use and overdoses. This end-to-end public health crisis highlights the need to implement prevention and treatment interventions. Prevention interventions work. They protect from the devastation of drug use, and when delivered early in life, they can also help avert adult mental illnesses. Prevention interventions aim to decrease risk factors while enhancing resiliency and are implemented through family, school, communities, and healthcare. Evidence-based prevention saves lives and money, and some studies show these benefits even extend to future generations. The Healthy Brain Study and the Child and the Adolescent Brain Cognitive Development Study are two large longitudinal investigations of human brain development. Together, they span the prenatal period through young adulthood. And the findings have already started to illuminate biological and environmental influences on mental health and are expected to inform prevention interventions. The healthcare system can also play a key role in prevention and treatment through screening for substance use and delivery of brief interventions or referral to specialty treatment. Identification of drug use can also serve as a sentinel symptom of a mental disorder that can then be treated. When substance use disorders occurs along with other mental illnesses, both disorders must be treated. Medications and behavioral therapies are effective in treating substance use disorders with or without comorbidities. However, less than 13% of people with substance use disorders receive treatment. This percentage is even lower among Black Americans, among whom we are currently seeing the fastest rate of growth in overdose deaths. Even for individuals with substance use disorders and psychiatric conditions, fewer than half received any treatment. To address this gap, NIDA is prioritizing implementations and services research. The NIDA Clinical Trial Network, or CTN, has shown that opioid use disorders can be successfully treated in emergency departments and other healthcare settings. CTN is now assessing new models of treatment delivery through pharmacies and telehealth. The NIDA Justice Community Opioid Innovation Network is testing ways to expand addiction treatment in jails and other justice settings. And the Healing Community study conducted in conjunction with Samsa is investigating how evidence-based interventions can reduce opioid overdoses in some of the hardest hit communities in our country. NIDA also helps biotech startups develop technologies that connect people to care, provide or support treatment, help people sustain their recovery, and even facilitate overdose prevention. While there are effective medications for opioids, alcohol, and tobacco use disorders, high relapse rates still remain. Critically, there are no medications for other drug use disorders. Thus, NIDA is prioritizing the development of addiction medications and treatment, including those that address the intersection between substance use and other mental illnesses. The escalating loss of life due to drug addiction has made evident the urgent need for interventions to prevent and treat emotional distress and mental disorders as key strategies for addressing the overdose crisis. Thanks for inviting me to testify.
Thank you very much to all of our witnesses. We appreciate your being here today. We will now begin a round of 5-minute questions, and I again ask my colleagues to keep track of your clock and stay within those 5 minutes. Assistant Secretary Delphin Rittman, this pandemic, as I said, has been especially difficult for children. They have dealt with major disruptions in their daily lives. Many have lost loved ones due to COVID-19. And meanwhile, parents and caregivers are really stressed, making what has been a really difficult time even harder for families and for kids. I know as a mother and a grandmother and a former preschool teacher, I am very committed to making sure we're doing everything to meet the needs of our children and our adolescents and to address this real national emergency in youth mental health. Can you tell all of us why it is important to provide kids with high-quality mental health screening and prevention and intervention and treatment services?
Thank you so much again for convening as Chair Murray. You know, it is so critical to address the mental health needs of young people. We know even before the pandemic, young people were struggling with a range of mental health challenges, and as a function of the pandemic, we've seen those challenges increase. So putting programs and strategies and training and technical assistance in place to be able to address the needs of children struggling with mental health challenges is a priority of Samsa. For example, one program that we have is Project Aware, that's promoting awareness and resiliency in schools. It's a wonderful program that provides training and technical assistance for school personnel to be able to recognize children that are struggling, but then also connect children who are struggling to care and to resources. And so that's a program that we, in fact, have been able to scale up through American Rescue Plan resources, and one where we're seeing significant impacts across the country. We've also developed, as I mentioned, the HOPE framework, so working to ensure that children and families are connected to health, so healthy opportunities and opportunities to be able to improve and advance health. Again, opportunity to be able to reach their full potential and be screened for any risks, and then equity, you know, certainly ensuring that those services are equitable. And so that is a framework that essentially encapsulates a range of programs and initiatives across SAMHSA to be able to ensure and promote the mental health and well-being of children. But this especially now is an important time to address mental health. And again, we have a range of programs. To include mental health first aid, that's an additional training program that provides training and support for communities, again, for schools and individuals on request, really, faith communities as well.
Great.
To be able to recognize the needs of and recognize when young children are struggling.
Okay, thank you. According to estimates released actually just last week, more than 105,000 Americans died from drug overdoses from October 2020 to October 2021. That's the highest annual total on record. In my home state of Washington, we've seen a real drastic rise in synthetic opioid use. Our largest county, King County, set a record high of overdose deaths. Those are really tragic and unacceptable numbers, and they make clear that we really need to invest in treatment, including medication-assisted treatment, or MAT, and prevention services for opioid use disorder. But right now, as I said, just 1 in 5 Americans with opioid use disorder receive MAT, and there are significant disparities in access to that treatment. As overdose rates are rising fastest among Black people, we also know Black communities are less likely than white ones to have access to those that they need. So as this committee looks at putting together legislation to combat substance use disorders and overdose deaths, I really think we have to do everything we can to expand access to prevention and treatment services and reduce those disparities in care. Director Volkov, I wanted to ask you, how would improved access to treatment, including medication-assisted treatment, help reduce those disparities?
We know that the most effective intervention that we have against overdoses is providing medication for opioid use disorder. It decreases your risk of overdosing by at least 60%. But unfortunately, as you mentioned, a very relatively small percentage of people that can benefit are given access to treatment. And the treatment also is not necessarily continued. So we need to not only expand the number of individuals that can be treated, but ensure that we have the support systems that will allow them to remain in treatment. And we have to take advantage of healthcare systems and involve partnerships with justice settings so that we ensure absolute equity in access to these treatments. The parity law determines that you should be treating addiction as a medical condition, and yet this has not been properly implemented. And we need to ensure that the workforce is able to provide the treatment. So,
Okay, thank you very much. And Senator Burr, you're deferring to Senator Collins. Senator Collins.
Thank you. Thank you, Senator Burr. Dr. Delvin Ribman, in Maine last year, we had 636 deaths, a 23% increase, primarily as a result of fentanyl. This is the highest level we've ever experienced. But what is equally troubling is if you look at total overdoses in 2021, the number exceeds 9,500. And what I'm hearing from law enforcement and public health officials is that they need data on non-fatal overdoses in order to identify and investigate the sources of opioids and fentanyl and other drugs in their communities, and to be able to direct people to drug treatment programs. I'm working on a bill based on recent GAO recommendations, which would require the administration to improve the timeliness, accuracy, and accessibility of both fatal and non-fatal overdose data. During our meeting prior to your confirmation, you described yourself as a data person. Would you support legislation to provide better information on non-fatal overdoses? Because if we're just looking at the tragic deaths, we are missing the picture.
Yeah, thank you so much for that question. And, I think it's right on. It's so important that we have a good sense of both overdose data as well as non-overdose data. Would be definitely interested in talking with you further about that. I think to the extent that we can understand some of the non-overdose trends as well, it could help to inform programs and services and interventions. So happy to have further conversations about that. I do believe that would be an important area of work.
Thank you. The next question I want to ask is for you also. Maine has the terrible distinction of having the second highest rate of neonatal abstinence syndrome in our country, even though the number of babies born in our state with neonatal abstinence syndrome has declined somewhat. But still, in 2020, 901 babies were born drug-affected. As a member of the Appropriations Committee, I've encouraged the administration to enhance efforts to screen, treat, and support infants through the WIC program. USDA designates neonatal abstinence syndrome as a nutrition risk, but WIC programs do not currently have uniform evidence-based nutrition educational materials. Does Samsa coordinate with USDA on this issue?
Yeah, so the WIC program is, and thank you for that question, is a USDA program, although we do have coordination and collaborations with USDA and can certainly develop additional work in this area. We currently have collaborations related to rural technical assistance related to opioid use, but can certainly expand our work and collaboration in terms of the WIC program as well, which they administer.
I certainly hope that you will. It's really a terrible problem. Ms. Johnson, my final question is for you. It has to do with the STAR loan repayment program that is administered by HRSA. It offers loan repayment to eligible substance abuse disorder professionals who agree to work in areas that are located in the country with overdose rates that are greater than the national average or have mental health professional shortages. Unfortunately, what we're finding in Maine is that some clinicians have been denied loan repayment because HRSA does not consider telehealth patient care unless both the originating site where the provider is located and the distant site where the patient is meet the geographic criteria. And that's in conflict with the flexibilities that Congress enacted to enable access to telehealth during the COVID public health emergency. I've written to HRSA on this, and I'm told that you need a legislative fix. Would you support making such a change to ensure that qualified substance abuse disorder professionals are not disadvantaged because the care delivery for vulnerable patients has shifted to telehealth during this pandemic, particularly for rural areas and underserved communities?
Thank you so much, Senator, for the question. As you know, HRSA is the home of the Federal Office of Rural Health Policy. We are very dedicated to making sure that we are doing everything we can to get services and supports to rural communities. And increasingly, as you note, our loan repayment programs are reaching into rural communities, and we are doing everything we can to ensure those programs continue to grow in rural areas. We also have used a number of COVID flexibilities, as many as we can, throughout the pandemic for our loan repayment program. So I'm very interested in having a follow-up conversation with your staff about the opportunities here, because we want to support rural communities as much as possible.
Thank you.
Thank you very much, Senator Smith.
Thank you, Madam Chair. Thank you to all of you for being here today. Just following up on Senator Collins' line of questioning, this issue of building out and expanding the mental health care workforce is a crucially important issue. I hear about this all the time. People who finally kind of break through the stigma and the systemic challenges to say, okay, yes, I'm ready to get help, and then they face long waiting lists, wait times that sometimes in Minnesota will reach to months. And of course, we would never put up with that kind of waiting time if somebody was having a heart attack or had a broken limb. And so I think addressing this workforce shortage, which is often the cause of this waiting challenge, is really important. Let me just ask Ms. Johnson a follow-up question. I mean, I get from what you were saying that these loan repayment programs work to build out the mental health care workforce across the broad spectrum of providers, because it's not just psychiatrists, it could be a whole, across the whole range of providers. Is that right?
That's correct. There are a whole range of mental health professionals who are eligible to participate in the National Health Service Corps. We also have a Nurse Corps loan repayment program. And the advantage of these programs is that not only are we helping those individuals with loan repayment in return for service in underserved communities, but our data consistently shows that people tend to stay in the communities in which they originally practice. And so it is a long-term investment in those communities.
Now, another issue that I hear about all the time is that we have loan repayment programs that are getting folks into, that are getting people ready to go into training, but then we have a shortage of trainers. We have a shortage of educators. This is a challenge in Minnesota around nurses, not only in mental health training programs, but more broadly. So could you just talk about what we need to do to address that challenge of educators in the field?
I just really appreciate you raising the question, Senator, because before the pandemic, nurse faculty was a challenge. The critical issues that our heroic frontline nurses have dealt with throughout the pandemic has made it even harder for us to recruit individuals who have the time and resources and capacity to function in nurse faculty roles. We have a loan repayment program to encourage people into nurse faculty. We'd love to continue to grow and expand that work, but we also are, in my my role at HRSA, I am increasingly reaching out to health professions, leaders, and health systems leaders who have a shared interest in ensuring that we have a viable nursing workforce for the future, because I think this is, as Ranking Member Burr pointed to earlier, a place for public-private partnership to encourage individuals to work in nurse faculty is an important partnership.
Because you might have been a practitioner, the thing you would like to see is practitioners who then come into training and become an instructor, but often that requires, people are going to be hard-pressed to do that if they're taking a salary cut.
That's right. I mean, what we can offer is the loan repayment for you to be able to do the educational piece, but given the current dynamics of where the workforce is, it is a challenge on the salary side.
So I think there's more work that we should think about doing together on this, because if we are, I see in Minnesota pumping lots of resources, good resources, into loan repayment and scholarships, but then there aren't any spots. Because of this issue that we're talking about.
I would welcome the opportunity to work with you on this. This is a huge priority for us as well.
That's fantastic. That's great. Dr. Delphine Rittman, I'd like to ask you, take a bit of time to talk about this question of how we integrate behavioral health care better into primary care settings. We know that this is a powerful way to expand our national mental health treatment and behavioral substance abuse treatment capacity. And this strategy, of course, recognizes that it's health. It's not mental health separate from physical health. And the better we integrate, the more we're going to undo the barriers that we have up there to block access to mental health care. So in just the few seconds I have left, can you just talk a little bit about some of the models that are out there for doing this kind of integration and where you see the greatest opportunity?
Yes, and thank you for that question. So absolutely, this is an area that is one of the Samsa priorities as well. We have an initiative called PBHCI, Primary Care Behavioral Health Integration. That is a grant program that essentially integrates behavioral health screening into primary care settings. We know that's so important because often individuals will go to a primary care setting first before they'll contact or connect with a behavioral health provider. So if screenings can be done in that setting, it allows for the individual to be connected to appropriate services and supports. We also have the CCBHC model, which integrates behavioral health or primary care integration into behavioral health settings. So certified community behavioral health clinics provides that integration as well, which is critical.
Madam Chair, I know there's lots of interest in this topic. On the committee, I'm working with Senator Moran, amongst others, to try to figure out how to support this, and I want to just thank the Biden administration. I know that both of these issues I've raised are part of their broad national strategy to address these challenges, so appreciate it very much.
Thank you. Senator Cassidy, and Senator Cassidy, just let me say to you, we're all thinking of you and all the people in New Orleans for the horrific tornadoes that we were watching, and wish you all the best.
Well, thank you. Thank you. Thank you, Madam Chair. Thank you all for your service to our country in this issue. Dr. Volkov, you in your written testimony, and then several years ago, mentioned the potential role of marijuana, cannabis, upon the adolescent brain as being a precipitator of serious mental illness. Is that a correct statement of your concern?
Definitively, this is one of the areas that we are most concerned of with the legalization of marijuana.
So let me ask you, that would suggest that states which have had a more liberal legalization of marijuana, say Colorado, would have an increased incidence of serious mental illness among adolescents and young adults than a state with more restrictive laws and presumably less prevalence of usage. Is that a finding that you've had?
In the United States, there are no studies that have documented that. In Europe and across the world, yes.
Now, hang on. Is documented that more relaxed legalization of marijuana is associated on a population scale with increased incidence of serious mental illness? Just to be sure.
Specifically, in the United States, legalization by some states of marijuana has not been associated with an increase in adolescents' marijuana use. That is something that has not
Now, that
happened.
surprises me because if you relax blue laws for alcohol, there ends up being more alcohol use by adolescents in that given county or parish.
We are seeing significant increases in adults' use of marijuana in young people, but not in adolescents, which is different exactly from what you're saying with the alcohol.
Now, what about the young adult? Because the brain, as I recall, continues to develop maybe up till 30. If you're a male, probably 35. So does that young 20, is there an association with increased incidence?
Yes, there is. There is, for example, there's significant increase in the risk for suicidal behaviors and suicidality associated with marijuana use among young people.
And that is when controlling for other factors. And so that's just not a cause, that is just not an association, but it's suspected that it's causal.
It is an association after controlling for factors like depression, but in order to establish causality, you need to you require prospective studies that we're currently carrying on the ABCD.
Now, let me ask, and you may not have this data, but we've worked hard to expand the ability of Medicaid to address addiction disorder. Have you found that states with Medicaid expansion and our state regulations being more employing these tools Congress has given have had better outcomes for adolescent and adult addiction or not?
There is evidence that some of the states that have expanded Medicaid have been able to provide extended access to medications for opioid use disorders among young adults and adults. The data for adolescents is not as clear. Because the sample sizes are much smaller.
And are we seeing better outcomes, or are we just seeing greater utilization of drugs?
We are seeing better outcomes.
That's great. Dr. Delphine Rittman, Dr. Gordon spoke about the RAISE grant, and Senator Murphy and I worked in 2016 to expand access to these RAISE grants. Now, in my state, though, I just found out I got 30 people statewide enrolled, 20 in New Orleans, 10 in Baton Rouge, and no other city has these programs. Now, is that a function of inadequate funding, or is that a function of my state not completely employing? Because adolescent suicide, we're hearing, is a huge issue, serious mental illness, and yet something that Murphy and Cassidy were attempting to employ has not been widely deployed. What can we learn from you about this?
And thank you for that question, and we can certainly have additional follow-up conversations about this as well. I'd have to look specifically in terms of were there other organizations that applied for the resources or applied for the.
Is there adequate money there for it?
For the
RAISE grant for the coordinated specialty care, I think it's called, the CSC. Yeah. As a 10% set aside within Samsa for mental illness, is that adequate, or does Congress need to look at that? Because from Dr. Gordon's testimony and what I've learned before, it's highly effective. So I guess my question is, do we need to give you more money for this, or is it just get our states to apply for it?
Yeah, I mean, it is definitely an effective program, and if we are appropriated more money, we will gladly receive it, because it is a program that makes.
I'm still not sure I'm getting the answer to my question. Is more money needed, or is the state just not applying?
I'd have to go back and look specifically in terms of the number of states that have applied for that. I don't have that with me, but we can certainly follow up.
Can I ask Dr. Gordon, Dr. Gordon, any insight on that?
Regards to whether additional monies would.
No, whether or not, what's the reason why it's not more widely deployed?
Oh, well, I think it is a challenging program to administer. You have to be willing to implement some changes at a clinical level. But I can't speak to Louisiana's case. But one of the things that the research project demonstrated is that you can implement it in clinical settings, but you still have to have the will at the local level to do so. I can't speak to the level of funding and whether it's adequate for the situation. I will say that while there are thousands of Americans currently enrolled in these clinics, there are probably thousands more who would benefit from it. And so expanding access to coordinated specialty care for first episode psychosis is a good thing.
Got it. Thank you, Madam Chair.
Thank you. I'm going to call on Senator Baldwin next. I'm going to turn the gavel over to Senator Kane while I go and vote.
Thank you, Madam Chair. Along with the increase in overdose deaths that we've seen in the past few years, I've been very alarmed to learn of really heartbreaking reports of college students in my home state dying from accidental fentanyl overdoses on campus. So Dr. Delphin-Rittman, what can we do to bolster the efforts of the residential colleges and universities to play a role in preventing these tragic overdose deaths on campus, particularly deaths as a result of fentanyl contamination?
Thank you for that question. And it's true. The patterns and trends that we're seeing as it relates to the fentanyl related overdoses is truly troubling across the country, on college campuses, in communities, really across the board. So in terms of college campuses and within each state, there are prevention networks, really robust prevention networks that we fund through our prevention, in part through the Prevention Set Aside, as well as the SPIF RX grant. And so those grants provide opportunities for community-based training related to the dangers of fentanyl. It allows for wide dissemination of naloxone and training around naloxone administration. As you know, naloxone is a vital overdose reversal medication. So continuing to scale up programs and initiatives like that to blanket college campuses, and our strategy has really been to work to disseminate naloxone far and wide across the country as part of the HHS overdose prevention strategy. But certainly some of the prevention work that's happening at the community level, again, funded by block grant, but also funded by SOAR, the State Opioid Response Grant, can be real valuable resources that states can use to provide training on and technical assistance to college campuses and others about the dangers of fentanyl.
Thank you. You actually anticipated my second question, which is how can we get more naloxone distributed on and available in community settings at college campuses and the like. Mm-hmm. So I'll move on to the implementation of the 988 three-digit suicide prevention hotline. In 2019, I introduced that measure, and it was signed into law in 2020, converting from the 10-digit numbers that are available throughout the states to 988 to make it easier for Americans to get the help they need. I am concerned that states may not be ready to respond to calls when the new dialing code becomes available in July of this year. So, Dr. Delphin-Rittman, how is Samsa working with states to make sure they're prepared for the 988 launch this summer? And how many states are ready right now for this transition?
And thank you for that question. And I have to say also, thank you for your leadership in terms of helping this important piece of legislation come about. It is significantly transformative for our nation in terms of how we approach crisis responsiveness and addressing the needs of individuals that are in crisis and experiencing suicidal ideation. So, I mean, states are in many different places. We've recently invested $282 million in the crisis infrastructure within states. That is allowing them to shore up, scale up, staff up the crisis call centers. That is an integral part of the 988 transformation, as you know. But we're thinking beyond that. It's not really just about the crisis call center. It's also about the full continuum of care. So states are getting ready, and we are watching their metrics regularly, and they're improving in terms of the influx of calls and their responsiveness to the calls, texts and chats, in fact, that they're getting. In fact, later this week, we have a convening with states as well as a number of other community providers and national organizations around just this thing, operational readiness and working to ensure that the 988 launch in July, that we're ready to go.
Yeah, so right now, as I'm aware, only 4 states have taken action to approve additional funding needed to support the 988 services. and my home state of Wisconsin is not one of them. So I am very concerned that states will not act to make this funding available, and believe that we should be taking a look at additional federal funding opportunities for states to make sure that this works across the country for people regardless of where they live. Can you comment, is that your knowledge also, that the states are not accepting and implementing this additional funding yet?
You know, states are taking different strategies. I mean, some states have put legislation in that will that add in an additional tax that will help to support the call center. Other states, and in fact, we had a convening in partnership with CMS around thinking about Medicaid resources and funding to be able to support the crisis care continuum. So states are looking at a number of different strategies to include, in some instances, state funding. All states, except for 2, applied for the $282 million that I mentioned, and otherwise all states and in fact territories are engaged with us on a regular basis, having discussions around operational readiness. We'll be doing resource materials and guides to ensure that states have the materials that they need.
Thank you.
Senator Tupperville.
Good morning. Welcome. Thank you for what you do. You're kind of in a boat that's taking on a lot of water, and you got one little cup trying to get it out. Been in the coaching profession for 40 years. I felt like that every day when it came to mental health, addiction, around kids. It's tough. I just hope we start getting some answers to this. But, you know, I walk to work every day, not too far from here, and I see 6 to 8, 10 people on drugs, passed out. You can go within several blocks here and you can probably find one person a day that's passed away from it. It seems like we want to do something about it, but we really don't know how to start from the bottom up. And again, I've dealt with it all my life, and it's a sad situation. It's something that if we don't get in control of it, we're going to look at a huge. We got an epidemic now, but we're looking at 200,000 to 400,000 that's going to start dying from this. Is there any work with any of y'all with Homeland Security that determines or gets any reports from what's happening at the border from fentanyl? I'm not getting into border walls and all. I don't get into all this political stuff. But I was down there not too long ago. I saw enough fentanyl in the back of a truck that killed everybody in this country. And most of us hadn't heard of fentanyl. Most people in here hadn't heard of fentanyl until last year or so. And it's getting bad. It's an epidemic. So anybody got any thoughts on that?
Yes, definitively. I mean, what happens with fentanyl, it is very lucrative for the illicit drug market. So it started in 2016, and it's just have grown increasingly. Extraordinarily potent drug, so a very few milligrams actually can generate a very intense high, but it can also kill you. It's much easier to transport across the border. Mm-hmm. You don't need to cultivate. The synthesis of this compound is relatively easy. So what we have seen was initially it was used to contaminate heroin, and now we're seeing it contaminated basically almost all illicit drugs. And that includes prescription, illicit prescriptions, and this is probably one of the reasons why we're seeing increases in deaths from overdoses among teenagers and young people. It's being used to contaminate methamphetamine and cocaine, and this accounts for the very steep rise in deaths. So it is a lucrative drug, and it's much harder to contain.
And it's synthetic.
And it is synthetic.
Chinese are making it, and a lot of it's been made in Mexico, and it's coming up through our border. And hopefully sooner or later, we wake up. They could put just a certain amount in our air duct system in this building and either make all of us sick or kill us all. I mean, that's how deadly this stuff is. I really don't understand it, but I want to thank all of you for your work. One problem that I ran into when I was coaching is I'd bring in 25 kids a year that I would sign, and a few years ago, it wasn't over 10 years ago, 1 or 2 of them would have insulin problems, diabetics, not very many of them on drugs. Recently, you can ask coaches now, half to three-fourths of them are on Adderall or Ritalin. Where's that taking us, Dr. Gordon? Where are we headed with this?
ADHD is an illness that strikes many young people around the globe and in the United States.
Is it a disease? Do you inherit it?
It's a good question. There's a genetic component as well as likely environmental factors that contribute to the risk for ADHD. The treatment of ADHD with Adderall and other drugs can be very, very effective. But we have both an undersupply and oversupply problem. We have many, many children who could benefit from treatment for ADHD who are not getting adequate treatment or evidence-based treatment. And then we probably also have children who are getting it that maybe don't need it or misusing it. And so you have both of those situations in the United States. I think what we try to urge at the NIMH is an adherence to evidence-based principles. So quantitative evaluation of symptoms, appropriate treatment with medication for those symptoms. And when that happens, children with ADHD can do very well.
Yeah, well, thank you. Well, all this is a symptom. It's kind of like you can buy it anywhere. In colleges now, a lot of these kids, I don't know which one of them they take, but they take it to stay up all night to absorb, cramming for a test. Which one would that be? Would it be Adderall?
It could be. There are several different versions.
Yeah, and it's just, that's another drug that we're going to have a huge problem with. But I just hope we understand we're dipping water out by a spoon in a boat. And we're going to be in real deep trouble if we don't get control of the substances coming in this country. We got enough problems without those, but thank you for y'all's help and dedication in dealing with this, because it is an ongoing problem that's getting worse and worse. Thank you.
Senator Murphy.
Thank you very much. Thank you to all of you for your tremendous work and for your time before the committee today. Senator Cassidy and I, along with Senator Murray's help and others, have been really focused on this issue of mental health parity. We've passed several different pieces of legislation through this committee, got signed by the president since 2016. The latest piece of legislation we passed required the administration to do audits of insurance plans to see if they were actually in compliance with federal parity laws. What we know is that, your statement of benefits will often tell you that you have access to mental health treatment. When you go to get that treatment, you will face what we call non-quantitative treatment limitations, all sorts of prior authorization, bureaucracy, red tape that stands in the way of you getting that treatment. I forget the exact number that the department surveyed, but about 50 plans, and the report we were given in January essentially came to the conclusion that not a single one of these plans was in compliance with parity laws. And interestingly, when they notified the plans that they had set up these burdensome barriers to mental health care that they didn't have on the physical health side, the plans fixed those issues. And all of a sudden, thousands of people had access to mental health that they didn't have. Secretary Delphin-Rittman, great to see you. I want to ask you a question because I noticed that in the Samsa joint block grant application, there's some language in there that says resources should be used to support, not supplant, services that will be covered through private and public insurance. And so you kind of reference the fact that, it's supposed to be insurance that's on the front lines here, and then we're going to come in on the back end. But that sentence also sort of suggests a knowledge that insurance is not actually providing the kind of reimbursement that it should. So can you talk a little bit about how you approach this issue? I mean, because we don't want federal dollars to essentially be filling in what insurers should be covering. And this report we got in January tells us that we just have massive noncompliance in the insurance industry with existing parity laws.
Yeah. Thank you, Senator Murphy, and it's good to see you as well. And parity is such an important issue for the American people in terms of health care and ensuring that both primary care and behavioral health is appropriately covered. I mean, as you know, Samsa has no regulatory authority here, but we do see ourselves as in some instances, a convener, or we help to give states information around how they can advocate, and even families. We've convened policy academies. We feel that it's important for individuals as well as states and communities to know what the parity laws are. And so those policy academies, which we are looking to bring back, additional policy academies, are one strategy for helping states have information around how to work with providers and to promote advocacy in this area. And we have resources as well for individuals and families, and we feel that's important as well, because people need to know how to advocate if they're not having coverage for services and supports which they feel that they should be covered.
I think that's important, but insufficient, right? I mean, families ultimately are not going to be able to enforce this right because the sort of details of obstruction of care are so Byzantine. Often it really has to be regulators that do this job, and we definitely have more opportunity at the federal level to enforce those laws. Just one quick other topic for you, Ms. Johnson. I want to talk to you about the state of pediatric mental health. We talk about this problem we have with getting enough practitioners, but we've got tens of thousands of pediatricians who often, frankly, don't have a lot of background in mental health. And it seems to me one of the easy things we could do is just have a conversation with the profession to make sure that either in the initial training or in some postgraduate training opportunity, more pediatricians have a background in mental health and substance abuse, but particularly in mental health.
Thank you for the question, Senator. I think that is where we should be headed in pediatric and all clinical training, that clinicians across the board need to have training and exposure to mental health and substance use disorder needs and conditions. We need, in my view, we need primary care to be inclusive of mental health. And so that is what we're working on at HRSA and what we're going to continue to push forward on going forward. Thank you for your leadership on the Pediatric Mental Health Access program. We really see that as an exciting model for how we can continue to help clinicians who are in practice now get the kind of mental health supports that they need, build up their capacity. What we're seeing anecdotally from that program is really people being able, clinicians being able to handle more and more mental health conditions and refer fewer. So we're excited about continuing to grow that program.
And just very quickly, that program is a mechanism by which pediatricians can get a phone or virtual consult with a mental health practitioner. I agree that program, which is included in the 2016 Mental Health Reform Act, has already shown positive results, but that can be partnered with the pediatricians themselves having a greater level of expertise, and something that hopefully this committee will work on. Thank you, Mr. Chairman.
Absolutely. At the request of Senator Cassidy, we will introduce a statement for the record submitted by the Children's Hospital Association. Senator Murkowski, you're up next.
Thank you, Mr. Chairman, and thank you to the panel here. I just came from a meeting of a group of close-up kids from Teller, Alaska, a pretty remote little community north of Nome. And close-up kids have all kinds of probing questions that they want to ask, but when I told them that I was coming to a hearing on mental health, and particularly mental health as it may impact young people, all of a sudden the chatter stopped, because they knew that this issue was something that was immediate, it was real, and I think they were somewhat relieved to know that the grown-ups were talking about it. So I want to ask you, Dr. Delphine Rittman, specific to these behavioral health issues that we're seeing in younger kids and the rising number of suicide attempts. I've worked with Senator Rosen to introduce the Youth Mental Health and Suicide Prevention, which would authorize SAMHSA to expand their work and services to address mental health in K-12 schools. I've got a letter that I'd ask to be included as part of the record, where we have a statement from the president and CEO of the Matsu Health Foundation. And she shares that they had had a forum with all of the Matsuburo School District nurses, and the nurses were effectively demanding that we change our conversation from access to health care to access to behavioral health care. And what they did in the program there, they launched this back in 2017. They launched a behavioral health in schools program. They then did a survey just recently. When schools were asked whether they felt that the providers have helped support students and whether they're satisfied with the responsiveness of providers to meet the changing needs of students and staff, 100% strongly agreed. 100% of the parents surveyed that they were satisfied, and 66% of those parents said that they made changes as parents to better support their child. I mean, when you have this level of, wow, we didn't know we needed this, but I guess we needed this, and this is actually something that makes us feel better, or allows us to feel that we've got a place to speak to this. So I would ask whether, I would ask you to speak to the importance of authorizing Samsa to provide this kind of support, direct funding to local schools, so that we can be in the schools raising this issue, not just talking about health care, but talking about access to behavioral care. So if you would speak to that, if you would.
Yes, thank you for that question. And, we are in full support of something like that. I mean, we've seen significant impacts and positive impacts from our Project Aware grant, which is, very much what you're talking about. It's a program, a school-based program that is about increasing mental health awareness. It provides training and education for school personnel. It also provides components around linking students to services and supports. And we see positive impacts there. We see students being connected to care, being identified who are struggling, who might not be connected otherwise. So I think behavioral health with programs, initiatives within school settings are highly valuable. We know students are there, throughout the week, and so if they're struggling, a teacher or school personnel, if they're trained to be able to identify a student that's struggling, can help to connect that student to services. So I think those types of programs are very valuable.
Well, know that this is something that we want to continue to push on. And let me then ask this next question, equally concerning in Alaska, but really around the country, and that is military suicides. We have seen really an alarming increase up north that has caused a real focus to this from the top of the military command, as they're trying to do everything to improve quality of life and just address everything from sleep deprivation, because it's sunny most of the day in the summer and dark most of the day in the wintertime, how you deal with all of this. But we know that we're still dealing with stigma. We know that we are still dealing with concerns from those that say that seeking care is going to harm their career opportunities. I have worked over the years on the Garrett Lee Smith Memorial Act, and we're looking to reauthorize that. It has proven itself, I think, to be effective. The law always authorizes the Suicide Prevention Resource Center, which ensures that the grantees get appropriate information, training, technical assistance on suicide prevention. So a question again to you, if I may, as to whether or not you think there are opportunities for the Suicide Prevention Resources Center to collaborate with DOD, provide technical assistance. I want to make sure that we're not just leaving DOD alone in its own silo there to address suicide issues that unfortunately are more broadly symptomatic of what is happening across our society. So can you speak to whether or not there might be some relationship there with these two programs?
Yeah, and thank you for that question. Yeah, I think there are opportunities there. I, in fact, co-chair the Interagency Task Force on Veterans' Mental Health with DOD and VA. And this is one of the very issues that we're looking at, suicide. And so it's an ongoing collaboration. There are a number of, it's a whole of government approach, so a number of different federal agencies there. But I think there certainly are opportunities here. in terms of collaboration and providing technical assistance, for VA as well, and DOD as well.
Good, thank you. Thank you, Madam Chair.
Thank you. And Senator Murkowski, you ask unanimous consent to introduce the letter. Without objection, so ordered. And I believe Senator Kane introduced a statement on behalf of Senator Cassidy that needs unanimous consent. Without objection, so ordered on that. Senator Hassan.
Thank you, Madam Chair. I want to thank you and the ranking member for holding this hearing and for the witnesses for the work that you do, and to be here today to discuss what are incredibly important issues. Dr. Delphin-Rittman, the last time you testified before the committee, we discussed the State Opioid Response Grant Program. You spoke about the importance of reliable, consistent funding and firmly committed to ensuring that states like New Hampshire would avoid significant cliffs in state opioid response grants. I very much appreciate that commitment. I know that our staff have been working together to develop a solution so we can achieve this shared goal, and I look forward to continuing those efforts. How do large swings in federal funding to states from year to year, particularly funding for programs that are responding to the substance use disorder crisis, undermine those states' public health infrastructures?
Yeah, appreciate that question, and our staff did have a productive conversation this week, and so we are looking to continue the work that we discussed. It's consistent, stable funding. It is important. As a former state commissioner, I'm aware of that funding cliffs or swings or changes in funding can be destabilizing for the system. So some of our work around looking at the current SOAR grant is around looking to sort of mitigate or reduce any of those impacts. Some of our challenge there, though, is that we received significantly less than what was proposed in the president's budget. And so we're working with the resources we have to try to minimize those cliffs that we discussed.
Thank you.
Senator Hassan, let me just say that I agree that we need consistent and reliable funding. It's really critical to our state's efforts to respond and prevent to those drug overdoses, and it's important that federal funding is allocated in ways that don't result in unusually large funding reductions between years. So I appreciate you bringing that up.
Well, thank you. I appreciate that very much. And I just wanted to note as well, I know there was a discussion earlier about the importance of medication-assisted treatment as we deal with substance use disorder, and I want to note that there are still barriers at the federal level that prevent more providers from prescribing medication-assisted treatment, and it's why I'm so grateful to be working with Senator Murkowski on this bipartisan Mainstreaming Addiction Treatment Act to eliminate these outdated prescribing restrictions for medication-assisted treatment. So I look forward to working with all of you and with my colleagues on the committee to get this done. Following along the line of the substance use disorder crisis, I want to ask you another question, Dr. Delphin-Rittman. Frontline workers in New Hampshire have shared with me that they are seeing a resurgence in methamphetamine use, and data show that deaths involving methamphetamines roughly doubled between 2018 and 2021. How is HHS responding to that trend?
Yeah. So one thing that we've done there, because we're looking at that data and we see some of those trends as well, is states are now able to use a state opioid response grant to be able to address the patterns and trends and needs that they're seeing related to methamphetamine usage as well. And so the SOAR resources can be used to address and put together programs or initiatives, awareness campaigns to be able to address the methamphetamine challenges as well.
Okay, thank you. That's an important step forward.
Mm-hmm.
This is a question to the panel. Maternal mental health conditions are among the most common complications of pregnancy and childbirth. However, these conditions often go undiscussed and untreated due to insufficient resources and pervasive stigma. So I'd like to ask the panel, what barriers have you seen to a federally coordinated maternal mental health response? And why don't we start with you, Dr. Volkov, and we'll just work down the panel.
Yeah, thanks for the question. And for us, we have focused very much on the challenges of ensuring that we are able to screen and provide for treatment for women when they are pregnant, ideally before they get pregnant, for any substance use disorder. Because the data shows that without treatment, the outcomes can be very negative for the mother herself and also for the newborn infant. The research shows that that intervention is necessary not just during pregnancy, but also the support that follows post-pregnancy to ensure that the woman is able to stop taking drugs or stay in treatment. The data also shows that pregnancy actually is a moment where women are much more likely to be receptive for accessing treatment, and thus is a lost opportunity not to provide it. Our research is ongoing to try to figure out which are the models of care that are most effective and which medications we can give to pregnant women safely, and how to monitor once the baby is born to ensure that they will have the greatest likelihood of success.
Thank you. And Dr. Gordon, if we can just go down quickly because we're running out of time here, and then I can follow up.
Yeah, one quick challenge I see is ensuring that maternal health care providers have the expertise and consultation necessary. So expanding collaborative care for maternal health care providers is one potential solution to that challenge.
Well, thank you, because I've introduced the Bipartisan Triumph for New Moms Act to improve this kind of coordination. The bill would create a federal task force and national strategy to expand mental health resources for new mothers. So I look forward to working with my colleagues and all of you, and I don't know, Madam Chair, if the last two panelists can quickly answer.
If they could do it for the record, that would be very
okay,
helpful.
we'll do it for the record. Thank you so much.
Thank you. Senator Braun.
Thank you, Madam Chair. Thank you all for coming in today. It's obviously an important topic. Question will be for Dr. Gordon, and then one for all of you. After being subjected for such a long time on wearing masks, and when the guidelines came out recently, most Americans in the country can now be mask-free. And of course, it always comes back to kids that still seem that there's an error on the side of masking when maybe they are in that group that is least prone to significant impacts from it. So what is your feeling on whether that is a good decision, and how has that impacted other developmental, emotional issues that come along with, being confined with a mask for all this time?
Data show that across a broad range of social, behavioral, and emotional outcomes, allowing kids to attend school in person is of the utmost importance. Accordingly, the Biden administration has prioritized that in their COVID response plan. Now, mask wearing can be a crucial part of a layered prevention strategy to allow children to remain in school when the conditions of the pandemic merit it. And it has been shown to reduce closures of at least daycare centers. The data for schools are not yet available. NIMH and other institutes, including NICHD, continue to study the impacts of both the pandemic and mitigation strategies like mask wearing on social, cognitive, and emotional development. To date, there are no studies that reveal any significant harms of mask wearing, but they have shown significant harms of school closures. So we look forward to continuing that research and making sure that we know for sure the effects of mask wearing and other mitigation measures of the COVID pandemic on children, but so far we have not seen any adverse consequences of those particular ones.
Thank you. And then one of the tragic consequences of trying to manage COVID from the mental health side has been, the overdoses that we've had to contend with. I'd like you to comment particularly on fentanyl, and is there anything else that's cropped up is contributing to that, and the other three panelists as well. We've got about 2.5 minutes left.
For
okay.
Yeah, there are two elements that are contributing. One of them is the social isolation and the uncertainty as stress has increased the risk of people to take drugs, and those are more likely to be exposed to synthetic drugs like fentanyl and others. And the second crucial element is, since the pandemic, the seizures of fentanyl has been increasing quite dramatically, making it very available. And also, as I mentioned before, it is increasingly used to contaminate other drugs. So those two elements, people being more vulnerable to taking drugs, while at the same time access to extremely dangerous drugs in the illicit drug market.
I certainly defer to Dr. Volkov on the fentanyl question. On the other, As an agency that focuses on maternal and child health, we just reinforced Dr. Gordon's point about the critical importance of children being in school. We have seen, because we serve underserved communities, how important it is for children to be in school to receive a series of services, whether those are healthcare services or whether that is key nutritional support and the like. And in order to do that, we want to make sure that children are following the appropriate public health mitigation guidance and responding to that as CDC continues to update that.
Yeah, and I'll just add that, in terms of the fentanyl, because of the patterns and trends that we're seeing, it's just increasingly more important that we have naloxone disseminated far and wide. So again, through our state opioid response grant, as well as block grant dollars even, states and communities can purchase naloxone to help reverse overdoses.
Very good, and I think it's sad that most of it gets produced somewhere else, comes through the southern border, and I think fixing that source would make a job a lot easier for all of you that have to contend with it. So I just hope that we get our hands around it to stop it at its source, and that looks like it's still to be accomplished. So keep up in the meantime all the good work to try to remediate it. Thank you.
Yes, Senator Rosen.
Thank you, Chair Murray. Thank you for holding this hearing, for your commitment to bipartisan process to reauthorize, to improve, to expand these key federal mental health and substance abuse disorder programs. And I just look forward to ensuring that Nevada's voices are heard throughout the process. And so I want to build a little bit about Senator Murkowski and I have been doing a lot of work together on this. And so one program that's been incredibly helpful in Nevada is Samsa's Mental Health Awareness Training Grant Program. You alluded to it earlier. We have dire shortages of mental health care providers, workforce training. That's a subsequent question we have to address. We can give all these dollars, but we need a workforce. But this federal program's been a critical lifeline, particularly in rural parts of our state, like Nye, Esmeralda, and Lincoln counties. They've used this grant funding to improve access to evidence-based mental and behavioral health training for first responders, for parents, teachers, school staff, community members, to first of all better recognize and then respond to unmet mental health needs of our communities and help prevent mental and behavioral health issues from escalating. So, Dr. Delphin Rittman, as this committee works to reauthorize this important program, what has Samsa learned over the past 5 years about potential improvements we might make to make it more accessible for everyone, particularly in our underserved, our rural communities? What should Congress be looking at to help fix this?
Thank you for that question and for your leadership in this issue. This has been such a critical program for us. Mental health first aid and the mental health awareness training programs it provide a wonderful opportunity just to increase awareness about mental health challenges. These trainings are done across the board in school settings, in faith communities, within other community centers. And what it does is it allows community members to be able to recognize children that are struggling or just anyone that's struggling. What we find is that people do get connected to care, and I actually have some data on that I'd like to share. So last year alone, so 2021, 38,000 individuals were trained in mental health awareness training, and 125,000 individuals were connected to care as a function of those trainings. So I think one thing we've learned is that it makes a difference. It makes an impact. People are being connected to care as a function of this increased awareness.
Well, I think it just increases our compassion and empathy for others and allows us to reach out. Sometimes that's maybe the most important first step, right?
Yes.
But speaking of reaching out, like I said, working with Senator Murkowski on being sure that we use these Samsa dollars down at our K through 12 schools, because Nevada's Clark County School District, we're top of a list that no one wants to be top of. We lost 20 students in 2020 to suicide. And so we have to do a lot more to be sure that our students are just being taken care of, particularly through COVID. And so we have to get that funding directly to the students. We need workforce training. I know you've spoken about this, about Project Aware. Doesn't allow the funding to go directly to local school districts. We think that's really important. I I know you've already committed to working with Senator Murkowski. We'll work together on this bill, so I won't ask you to repeat your answer. I know you'll be glad, I hope you'll be glad to work with all of us, and I'm sure you will on that. And to your point, what I really want to talk about in the remaining time is address that workforce issue or training issue, whether it's lay people or people who we're going to put to the schools, because if we bring this money down, it's no good if we don't have the counselors. So can you talk to us about the workforce shortage, and how do you think Congress can help provide, expand our provider capacity for health in the health professional area?
Yeah, thank you for that. I mean, we certainly are seeing a workforce shortage. You know, programs like Minority Fellowship Program make a difference, or other fellowship programs, loan repayment programs make a difference as well. And you know, my colleague Ahursa can share about that as well. But you know, I think programs that that essentially create incentives for people going to you know, entering the behavioral health professions. For me, it made an impact, and as it came up earlier in this committee, often individuals will stay and continue to work in the communities where they do their internships or where they do, you know, some of their training programs. So those types of programs do make a difference, and then also certainly loan repayment programs make a difference as well.
Thank you. I appreciate that. I'm out of time. I just will ask Dr. Gordon, for the record, you can submit it offline about seniors' mental health. We also have a lot of issues there with social isolation and some of those challenges. So we'll submit that. You can respond for the record. Thank you. Thank you, Madam Chair.
Thank you very much. And I'll turn to Senator Kane for wrap-up, and thank you again for filling in for me.
Absolutely, Chair Murray, and thanks to the witnesses. This has been a really good hearing. I want to stick right where Senator Rosen was at the end of her questioning about workforce issues, and particularly workforce in helping folks with substance use disorders. My experience has been, and I wonder if this is more than anecdotal, is that some very effective folks in this workforce are people who've had substance use disorders themselves. But I also find, as I travel around Virginia and talk to people, that they, and how legit this is or whether it's a perception, they still feel like if they've had a substance use disorder, particularly if that's led to any criminal conviction, that they can be challenged in licensure, and regulations often get in their way in terms of being able to be in the workforce. They can volunteer, they can be part of a support group, but if they want to make it a profession and help others who've, because with using the experience that they've gone through, there can be barriers in their way. So I wonder if you might talk about that, because if we are looking for a bigger workforce, we wouldn't want to keep out of the workforce people who've had a life experience that would make them particularly effective.
Yeah, I'm happy to comment on that. I mean, we have absolutely seen that individuals in recovery, so peer support specialists, recovery support specialists, make a meaningful difference in terms of connecting people to care. And giving people hope. Often we find recovery coaches share their own stories of lived experience and often are able to help connect people to services and supports. In fact, we've seen with our state opioid response grant, many states now have programs where they have recovery coaches connecting with emergency departments. So when an individual is brought to an emergency department, they're linked up with a recovery coach, and then the recovery coach helps with system navigation, helps them get connected to care, or helps them with whatever they need. Often they say their first question is, you know, how can I help you in your recovery today? So those programs make a difference. We've seen recovery coaches also in working in methadone programs, working in supported employment programs, and it's an area in terms of Samsa that's a priority for us in terms of expanding our recovery work, and we recently announced a recovery office of recovery. Recovery is also one of the pillars of the HHS overdose prevention strategy as well.
I would just add, if you don't mind, sorry. Peers, people with lived experience, are part of the solution here, and we are not going to succeed in the way that we want to in combating the opioid epidemic, combating the substance use disorder challenges without engaging people who have lived experience. They have the unique ability to connect people to care, and we want to support that. The licensure issue that you raise, I suspect, is a state-by-state issue. In my prior to this role, I was the Human Services Commissioner in New Jersey. We didn't experience that issue there, but I will commit to you, if you are seeing that in other places, Miriam and I want to be vocal and help address those issues, because we want peers to be part of the solution.
Excellent. Related topic that I want to ask about is folks who are incarcerated. So 2 million people in the United States, 25,000 in Virginia. Of this population, about 2/3 have a substance use disorder history, often a current challenge, and about 1/4 of those have opioid use disorders. The data shows that folks who receive treatment, including medication-assisted treatment, are more likely to engage in post-release treatment and to stay in treatment longer. There's challenges with medication-assisted treatment in prisons and jails. What might we do to enable people to get this kind of treatment that's going to help them while they're incarcerated, but more particularly when they're no longer incarcerated?
Mm-hmm. Yeah, thank you for that question. Such an important area that individuals who are connected to the justice system get connected to services and supports. So SAMSA has our drug court initiative and grants, which help to divert individuals from further involvement in connection with the justice system and into behavioral health treatment. Individuals are then able to get connected to medication-assisted treatment or other services and supports that they need. So that's one initiative. I think diversion programs really make a difference in terms of connecting people to care, but also in-reach programs. So programs that connect people to services and supports pre-release. And those programs can help to ensure
How about particularly the issue of medication-assisted treatment for those who are incarcerated?
Yeah. So we are supporting a number of prisons and providing technical assistance around administering buprenorphine or other forms of MAT within criminal justice settings. So we have done some technical assistance there, and so that's an important area as well. So that for individuals that are in prison, for them to get connected to MAT as well.
I have one last question that I want to raise. The committee was very helpful in getting a bill passed that President Biden signed last week called the Lauren and Breen Healthcare Provider Protection Act, which was to try to provide mental health assistance to our frontline healthcare workers who've had a lot of challenges even before COVID and then particularly since COVID. And as I was thinking about that bill and talking with the Breen family when we were at the bill signing last Friday, I started to think about other parts of our workforce who have really had challenges during COVID. And a friend of mine said, what about last responders? And I said, tell me, I haven't heard that phrase. What do you mean by that? And talking about people who work in nursing homes and long-term care facilities where the illness and death tolls have been extremely high. Often these workers are paid very little. These are some of the lowest paid workers in our system, and yet they've seen and experienced themselves. Many of them have gotten sick and died too. What have you seen with our long-term care workforce in COVID, and how might we approach this issue of mental health resources for them?
Well, I would say thank you, Senator, for your leadership on this issue, and to the chair as well. We were, with American Rescue Plan resources, able to do $103 million in awards to 45 grantees to support healthcare provider resilience and help reduce burnout. As part of that, one of those awardees is a technical assistance center, which we're hoping to leverage all the learnings from this work so that it's not just the 44 grantees and the technical assistance center that get the benefit of those resources, but that we can help healthcare providers across the country in addressing this issue. But you raise a very important point about frontline long-term care workers who have been heroes throughout the pandemic, and I look forward to working with you on ways that we can address their mental health needs going forward.
Great. Thank you. Thank you, Chair Murray.
Thank you. Very, very good point. That concludes our hearing today, and I want to thank all of our colleagues and all of our witnesses, Assistant Secretary Delphin Rittman, Administrator Johnson, Director Gordon, and Director Volkov. Really important hearing, and appreciate all of your thoughtful input. For any senators who wish to ask additional questions, questions for the record will be due in 10 business days, April 6th at 5 p.m., and the committee will next meet Tuesday, March 29th in 430 Dirksen for a hearing on how we can strengthen families' finances and improve their retirement security. That the committee stands adjourned.